Hey, good afternoon, everyone. Welcome you all in Pedia Academy by Dr. Pankaj. So, again, I welcome you all in this channel and our new test series, which is NEET SS Pediatrics Test Series, which is divided into 72 subject-wise or topic-wise test. We'll discuss it later also. So, without further delay, let's start our discussion of so today we will discuss tables from Nelson textbook of pediatrics from neonatology section. It is very important to remind you all this is a part of Nelson based daily test series for NEET SS 2025 and it will contain 12-week long test series, 72 subject wise test, 6 full line test, 100% Nelson based and 100% exam oriented. So you can join at pediacademy.com. Okay, so without further delay, let's start our discussion of today, which is twins. Okay, so twins basically twinning at arterial side. One twin is called as donor and another twin is called as recipient. So basically two donor and recipients are there, donor and recipient. In this scenario, we have to see some features of both. Okay, so just see, donor side will be oligohydramnios, less, and venous side or recipient side will be polyhydramnios, one most common differentiating factor. Intrauterine growth restriction will be seen in donor side of twin, and hydrops will be seen in the recipient side of twin. For same logic, donor side of twin will be pale, a recipient side of twin will be plethoric, anemic and polycythemic, hypovolemic, hypervolemic, hypoglycemic, cardiac hypertrophy, microcardia, and myocardial dysfunction. Okay, arterial thin wall and thick wall. Basically, donor is shrinking. Just remember this mnemonic: donor is shrinking and recipient is enlarging. Okay, so by this concept, you can see in this scenario oligohydramnios, IUGR, pale, anemic, hypovolemic, hypoglycemia, microcardia. Just remember these three, four things. Questions are expected out of this. Okay, so another thing we'll discuss symmetric and asymmetric IUGR differentiation. Okay, as we saw, symmetric IUGR present with earlier gestation, often second trimester, ultra important. Asymmetric IUGR starts with later gestation in third trimester. Percentage of all IUGR cases, 70 to 80% are asymmetric IUGR. So asymmetric IUGR is most common among IUGR. Okay. Etiology. What is the etiology? As explained earlier also, if symmetric IUGR is in earlier gestation, in that gestation genetic disorders and congenital infections will prevail. Placental insufficiency is the cause of asymmetric IUGR. If you do an antenatal scan, so in this proportionality decreased HC, AC and femur length. Basically it is symmetrical IUGR as the name suggests. But in asymmetric IUGR only abdominal circumference is decreased. So in question it will be framed like that. In asymmetric IUGR HC is decreased, AC is decreased or femur length is decreased. Our answer should be abdominal circumference is decreased. This is potential NEET SS question. Cell number is decreased in symmetric IUGR, which is very important. Asymmetric IUGR because it is late presentation, cell formation has been completed, so cell number will be normal. But cell size, just remind you, cell size is normal in symmetric IUGR and cell size decreased in asymmetrical IUGR. So this is the difference. Okay, malnutrition features is less pronounced or more pronounced in asymmetrical IUGR. Basically, the asymmetric IUGR thing you have to remember 70 to 80%, only abdominal circumference decreased, cell number normal, cell size decreased. Okay, next we'll see this maturity rating of modified Ballard scoring. Basically, I have given just this scoring system, not the whole, because they ask, okay, what is the score starts from -10 to 50 and weeks 20 to 44. Basically, you have to remember the starting point of score and end point of score because this is MCQ and weeks from 20 to 44. Add 5 uh, in this score, those minus 10, minus 5, 0, 5, 10, 15, and weeks add plus 2, 22, 24, this. Okay, you have to remember like this. Any question arises from this, like at 40 score, the gestational week will be 40. At 50, it will be 44. Similarly, you can see the difference in this. Okay, so many questions can be framed from this. Okay, this is a proposed risk classification of infant with PHVD. So this is ultra important post hemorrhagic ventricular dilatation. Okay, they'll ask you which is the green zone, which is yellow zone, and which is red zone. Okay, so every zone they'll ask. Basically, these are the criterias. Ventricle size with the following VI. VI means ventricular index and AHW means anterior horn width. Okay, so you have to remember VI should be less than 97th percentile, AHW less than 6 millimeter. Yellow zone ventricle size is more than 97 and AHW more than 6 millimeter and TOD is more than 25 centimeter. TOD means thalamo-occipital distance. Just remember these. And red zone you have to remember ventricle VI is more than 97 percentile plus 4 millimeter. AHW is more than 10 millimeter and TOD more than 25 millimeter. Just remember these values. Okay, these are ultra important because based on this they will ask which zone of PHVD this patient lies. Okay, in this red zone, we will focus on the red zone now. Any of the following criteria like head growth more than 2 centimeter per month, separated sutures and bulging fontanelle. So this will be red zone. So just we will discuss red zone treatment. Consider lumbar puncture 2-3 times and neurosurgical intervention with VP shunt. Okay, green zone we have to observe, we have to do cranial ultrasonography until stable. Similarly, for yellow zone, you have to do LP 2 to 3 times and cranial ultrasonography. The ultrasonography criteria are there. Basically, in this table, they will ask you what is green zone, yellow zone, red zone definition, and what will you do in red zone. Okay. There are some poor predictive variables for death or disability after HIE. So basically HIE, these are poor prognostic factor. This is ultra important table because in exam they'll pick directly lines from Nelson from this table. So low 0 to 3 10 minutes EPCAR score we know because this is poor outcome. Need of CPR in delivery room, yes. Delayed onset more than 20 minutes of spontaneous breathing, severe neurological signs, seizure onset less than 12 hours. Just remember, this is less than 12 hours, not more than 12 hours. This was previous INI SS question and many students fumble at that. Next is severe prolonged around 7 days easy finding including burst suppressions. This was NEET SS question. Burst suppression pattern is poor prognostic factor post HIE. Prominent MRI basal ganglia thalamic lesions are the poor prognostic factor. Oliguria, anuria more than 24 hours, or abnormal neurological examinations more than 14 days. Basically, you have to remember these values also 14 days, 24 hours, 7 days, less than 12 hours, less than 20 minutes. Because these are ultra important, you have to remember these. Ultrasound diagnosis of periventricular leukomalacia. This is also important. In this, what they say, ultrasound appearance like echogenic foci, bilateral, posterior more than anterior. If this scenario is there, generally this is seen in first week. So what are the correlation? Neuropathological correlation, necrosis and congestional hemorrhage more than 1 centimeter will show this. If you're able to see evolution foci, cysts are there, so it must be of 1 to 3 weeks. Cyst formation secondary to tissue dissolution, size more than 3 millimeter. If ventricular enlargement is there and disappearance of cyst, this was INISS question, disappearance of cyst appears at 2 to 3 months of age, post 2 to 3 months of age, deficient myelin formation gliosis, often collapse of cyst. Okay, so this table we have discussed twin classification, asymmetric and symmetric IUGR, PVHD risk factor, and this Ballard scoring, and HI poor prognostic factors, and periventricular leukomalacia ultrasonographic. So everything we are discussing so far is under hood of test series NEET SS Pediatric, which is available at pediacademy.com and also with the Android app. So now our discussion will shift to EEG assessment of asphyxiated term infant. Basically, Nelson is giving emphasis on EEG findings. So these are very important tables and potential exam questions. Okay. So detection of severe abnormalities like CLV-FT burst suppression. CLV means continuous low voltage, flat trace, and BSP means burst suppression in first hour. Okay, so they have positive predictive value of unfavorable outcome. Severe abnormality may improve within 24 hours. Rapid recovery of severe abnormalities associated with favorable outcome in 60% cases. Combination of early neonatal examination, early EEG finding, enhance positive predictive value and specificity. Basically, in this table, you have to remember this. If we are seeing these abnormalities, okay, so these abnormalities are important to consider because in this poor prognosis is expected if these abnormalities are improving within 24 hours. So this is a good sign. Okay. Another thing we will discuss EEG pattern of prognostic significance in asphyxiated term infant. So what are the EEG findings which are associated with good outcome, that is mild depression or less on day 1, normal background by day 7. So these you have to remember. If anything you have to remember, this is very important. Unfavorable outcome in asphyxiated term infant is due to EEG findings like predominant interburst interval more than 20 seconds on any day, burst suppression pattern on any day, isoelectric tracing on any day, or mild depression after day 12. Basically, you have to remember these values because direct one liner or direct line from this table can come in exam and you have to answer accordingly. So these are easy findings. We'll discuss bronchopulmonary dysplasia. Basically, this diagnostic criteria is slight bit old, but it is given in Nelson, so we have to see this. Okay, to simplify this, what you have to do, uh, just see if the patient is born less than 32 week or if patient is newborn is born more than 32 weeks. Okay, so time point of assessment of the newborn which is born at less than 32 week, we have to assess him or her at 36 week post-menstrual age or discharge at home, whichever is first. Basically, we have to screen him. Okay, so treatment with more than 21% oxygen at least 28 days. This is the major criteria. Means for 1 month, the patient or neonate should be on oxygen more than 21%. Mild, moderate, and severe BPD. Okay, breathing at a room air less than 30 or more than 30, or mechanical ventilation. This is very simple. If it is breathing at a room air, mild BPD. If it is requiring less than 30% oxygen, moderate BPD. If he requires more than 30% oxygen or mechanical ventilation, it is severe BPD. So it was for 32 week. If the newborn is born after 32 week of gestation, so we have to actually examine this patient less than 56 days. Let's say 56 days by 56 days. Criteria is same, more than 21% oxygen for at least 28 days, and mild is breathing room air, moderate again less than 30%, and severe is more than 30%. So this is simplified classification of diagnostic of BPD, but again examiner's favorite topic is BPD, so this table is ultra important and you can crack this table easily. Now we will discuss typical laboratory finding neonatal liver failure. So just see what are the DDs of neonatal liver failure: gestational alloimmune liver disease (GALD), HLH, hemophagocytic lymphohistiocytosis, mitochondrial, viral, ischemic. Okay, so just see where I am highlighting, we will focus on ferritin level. Gestational alloimmune liver disease, these like ferritin will be increased like 800 to 7,000, which is very significant. But in HLH, even it is increased more than 20,000. Even in viral, it is more than 20,000. So in GALD, in HLH and viral, this ferritin level increased. But just see the triglyceride level. Triglyceride levels are only increased in HLH, which differentiate them from other causes of neonatal liver failure. Lactic acidosis, as we all know, is increased in mitochondrial. Alpha fetoprotein may be increased in mitochondrial. So basically, these are the DDs of neonatal liver failure. Just see how you can differentiate. As we discussed, ferritin is increased in both HLH and mitochondrial, but HLH triglyceride will be increased. Okay. Next, we'll go to clinical feature of Kernicterus. So this is another important point. So it is acute form, okay, acute form and chronic form. So acute form and chronic form. Acute form again subdivided into phase 1, phase 2 and phase 3. 1, 2 and 3. So basically phase 1 lasts for 1 to 2 days, poor suck, stupor, hypotonia and seizures. This is non-specific. Phase 2 is middle of first week, hypertonia of extension muscles, retrocolicin fever. Just remember these two keywords in this: hypertonia, hypertonia and fever is ultra important. These are the keywords. Phase 3, after first week, hypertonia will be there. Chronic form in first year, hypotonia, not hyper, it is hypotonia, active deep tendon reflex, obligatory tonic neck reflex. After first year, movement disorders like choreathetosis, balismus, upward gaze, SN hearing loss. So basically these are Kernicterus acute and chronic form features. Now we will discuss some transfusion thresholds in newborn. Week 1, week 2, week 3 we will see like that. If respiratory support is there, the threshold will be 11, 10, 8.5. In absence of respiratory support, it will be 10, 8.5 and 7. So just remember like these, because you have to remember these values. If you read them twice or thrice, you will remember these values because these are very important. So in this slide, we have discussed EEG findings and their significance. We have discussed BPD diagnostic criteria. We have discussed neonatal liver failure DDs. We have discussed Kernicterus clinical features, and we have discussed transfusion threshold in newborn. Now we will discuss vitamin K deficiency bleeding. This is simple looking topic, but it is very important. Early onset disease, just remember the duration 0 to 24 hours. Classical disease is 2 to 7 days. Late onset disease 1 to 6 months. Okay, so you have to remember the potential sites of hemorrhage like cephalohematoma, GI and umbilicus in early, and ear, nose, throat, post circumcision in classical, and injection site generally is seen in late onset disease. These are the sites. What are the etiologies? They'll ask maternal drugs are etiology for early onset disease. This was previous NEET SS question. Vitamin K deficiency in exclusively breastfeeding is the cause of classical vitamin K deficiency. Cholestasis, malabsorption, beta lipoproteinemia, And idiopathic warfarin ingestion is the cause of late onset vitamin K deficiency. How we will prevent early onset vitamin K deficiency? Antenatal vitamin K treatment to mother and postnatal to infant. Very simple. Classical disease, how we can prevent this? Again, vitamin K at birth and uh, repeat vitamin K dosing is required. Late onset disease cholestasis management. Okay. And now we'll discuss syndrome of some syndromes by congenital infections. Okay, like toxoplasma, just remember keywords hydrocephalus and diffuse intracranial calcification in chorioretinitis. Rubella virus, cardiac defect, SN hearing loss, cataract, blueberry muffin lesions, very important. CMV, microcephaly, periventricular calcification, petechia purpura, hepatomegaly. HSV, skin vessel scarring. This is very important. Microcephaly, vesicular rash, trypanoma pallidum, bullous macular eczema, skin rash, rhinorrhea. Rhinorrhea is very important. Previous year question. Osteochondritis, varicella zoster, limb hypoplasia, cicatrial skin lesions. This was an NEET SS question previous year. Ocular abnormalities, cortical atrophy, parvovirus, non-immune hydrops fetalis. This is also PYQ. HIV is severe thrush, failure to thrive, recurrent bacterial infection, calcification of basal ganglia. This was again PYQ. Zika virus is microcephaly, lissencephaly, cerebellar hypoplasia, echinacea syndrome. Basically, you have to remember these syndromes by congenital infections. I will again highlight important one like hydrocephalus, choroiditis. So these you have to remember. The highlighted one are previously asked question or potential to be asked. Okay, yes. So these are important. So, late sequel of intrauterine infections. So, just see, hearing loss, we have discussed this. Hearing loss is universal among CMV, rubella, toxo, treponema, and Zika. Okay, dental and skeletal problems are in CMV and toxoplasma, it is generally not seen. So they'll ask in which infection late manifestation is not a part of this. So in CMV or toxoplasma, these dental skeletal problems are not that prominent. Developmental delay is throughout and seizure is everywhere. So basically, dental skeletal problem they will ask in which condition, which infection they will not be seen in CMV and toxoplasma. Again, very important. Okay. Now we'll discuss definition of systemic inflammatory respiratory syndrome SIRS and sepsis. So basically SIRS is systemic inflammatory response to variety of clinical insult, mainly two or more of the following. So two or more. So basically what we have to see, first is temperature, second is respiration, third is cardiac, fourth is perfusion, and four is perfusion. Okay, so any more than two, so temperature should be less or more, like less than 95 or more than 101.3. Respiratory difficulties like tachypnea and hypoxia, cardiac dysfunctions like tachycardia and hypotension, you can remember of two standard deviation, perfusion abnormalities like oliguria less than 0.5 ml per kg per hour and lactic acidosis. So these are the basically classification criteria of sepsis. So I'm just highlighting temperature, respiratory, cardiac and perfusion. You need two out of them. What is sepsis? Sepsis is the systemic inflammatory response to infectious process. So these definition basically you have to remember, these are important. We have discussed BPD. This is the new definition of BPD. Basically, what they say, for infant born less than 32 weeks of gestation with radiographic evidence of parenchymal lung disease, who at 36 weeks require one of the following FiO2 oxygen levels for more than 3 days to maintain SpO2 90 to 95% of a range. So basically, they have discussed this. less than 32 week. We are examining them at 36 week of gestation, and they are requiring FiO2 oxygen therapy for more than 3 days to reach at level of 90 to 95%. So remember, this sentence is very important to classify this. So just go through this sentence once again. So grade 1, grade 2, grade 3. Grade 3 is divided into grade 3 and grade 3A. If an invasive ventilation is there, so no 21% FiO2 and more than 21% FiO2. Okay, so basically just go through this grade 3A. Infant who dies between 14 days to 36 week post-menstrual age from respiratory failure secondary to parenchymal lung disease. So this is the definition of grade second B. This was asked in INI SS exam. So this is important. Again, if your patient is on and CPAP, nasal cannula, or nasal cannula less than 1 minute, you have to remember these values. Okay, I can't teach you these values, but you have to just go through just before exam. So this is your last 11th hour table. Okay, before going to exam. Okay, so in this slide we have discussed this vitamin K deficiency bleedings, neonatal syndromes caused by congenital infections, late sequelae of intrauterine infections, and this BPD new classification criteria and SIRS and sepsis criteria in pediatric patients. So with ongoing table discussion, I just want to remind you all that I have a collection of neonatal INSS neonatology base. Basically, it is also important for NEET SS pediatric also. I have compiled all recent AIMS protocol into fast track revision series, which contains around 10 lectures of approximately 1 hour duration. So just go through this playlist. This is complete package of neonatology recent AIMS protocol. Okay, so now coming back to our discussion, now I'll discuss PPHN management. Okay, how you will manage PPHN? So initial we will give oxygen, CPAP and mechanical ventilation, HFO, early surfactant ventilation, and INO if oxygen index is more than 15 despite optimized ventilation. This is first line. So what is first line is INO if oxygenation index is more than 15. If severe PPHN is, that is OI is more than 25, consider adjuvant therapy second line. So what is the adjuvant therapy? Eleuprost, and next is uh, treprostinil, okay, sildenafil, and optimize BP with fluids and vasopressors. Basically, first thing is this inhaled nitric oxide. This is the first line. Second line is eleuprost, this and BP management. If decreased myocardial function is there, add Meninol IV. If restrictive ductus or right heart failure is there, consider PGE1. What is the third drug? Third line drug is bosentan, which is oral. Okay. And if it is OI is more than 40, serial ABO, significant cardiovascular instability, ECMO is the main agent. So basically, this algorithm you have to remember. Next, we will discuss composition of surfactant. So basically, saturated phosphated choline is more than 50% is the main component, and other components like SPA, B, C, D, neutral fats and unsaturated phosphated choline. Okay, now we'll discuss this like uh, adverse reaction of drugs administered to premature infant. So just go through highlighted one: sulfasoxazole kernicterus, novobiocin jaundice, bicarb intraventricular hemorrhage, amphotericin B is anuric renal failure, indomethacin oliguria hyponatremia intestinal perforation, tetracycline is enamel hypoplasia, morphine is hypotension, urinary retention withdrawal, dexamethasone is GI bleed, hyperglycemia, furosemide is deafness, hyponatremia, erythromycin is pyloric stenosis. So here we discussed all this. So this is important discussion. Just go through this, and we have our Android app also available for this test series. So you can download this Android app. The link is in this description. So again, this is complete package of neonatology. If you see this Nelson based table and AIMS protocol based videos, along with if you solve all MCQs from this AIMS module, so this is complete package. You This is actually sufficient for NEET SS, and even it is good, good, or you can combine this with your preparation for INSS neonatology. So we will meet in another video. Till now, happy reading and revise neonatology.